Hello everyone, I am going to show an interesting case. This is a case of Achalasia cardia for which we are doing laparoscopic LS cardiomyotomy. You can appreciate the barium swallow study image. The esophagus is dilated. There is stasis of barium in the esophagus, and you can also appreciate the typical bird's beak appearance. This is CT image. You can appreciate the grossly dilated esophagus completely filled with fluid material, and in cross-sectional image you can also appreciate the dilated esophagus actually occupies around 50% of the right hemithorax. This is manometry image of this patient. You can appreciate there is absolutely no peristalsis in the esophageal body, and there is no relaxation of the lower esophageal sphincter during the swallow. After the introduction of high resolution manometry, the achalasia is categorized into three types: type 1, type 2 and type 3. In type 1, total aperistalsis and no relaxation of the lower esophageal sphincter. In type 2, there will be pan-esophageal pressurization. In type 3, there will be spasm of the esophageal muscles. So, in type 3, patient will have severe pain. You have to extend the myotomy into the thoracic esophagus. In type 1 and type 2 achalasia, the classical laparoscopic LS cardiomyotomy is adequate. This patient is having type 1 achalasia cardia. We use 5 ports. The camera is about 5 cm above and onto the left of the umbilicus. 2 working ports, 5 mm, and another 5 mm subspheroid port is used to retract the left lobe of liver. We lift the left lobe of liver anteriorly and grasp the diaphragm by using a tooth grasper so that it will remain in place till the end of the procedure. We are using grasper to retract the left lobe of the liver. We divide the gastrohepatic ligament and we try to enter a plane between the right crest of the diaphragm and the esophagus. We divide the phrenoesophageal ligament, and this division is carried out all around the esophagus. While doing anterior dissection, you have to be very careful. We should not injure the anterior vagus. Similarly, while doing posterior dissection, you have to take the posterior vagus along with the esophagus in order to avoid injury to the posterior vagus. And we try to create a plane between the left crest of the diaphragm and the esophagus, and we create a window behind the esophagus in order to introduce a bowel grasper from right to left, and we are actually tying an umbilical tape around the OG junction. By grasping this umbilical tape, you can give uniform traction to the esophagus downwards so that we can dissect it nicely into the mediastinum. You can appreciate the grossly dilated esophagus. And in chronic achalasia, there will be a fibrosis between the esophagus and the periesophageal tissue. So all this fibrous attachment needs to be lysed so that you will get good intra-abdominal esophageal length, and we can do myotomy comfortably. So while doing this, you should make sure that you are not injuring the pleura right pleura, and while doing posterior dissection you should identify the course of the posterior vagus in order to avoid injury to the posterior vagus. After doing this, we divide the short gastric vessels, few short gastric vessels, in order to release the fundus so that it will be used for posterior 270-degree Toupet Fundoplication. While releasing the short gastric vessels, you should be very careful not to injure either the stomach or the upper pole of the spleen, because as you go towards the upper pole, stomach will be closely adherent to the upper pole of the spleen. The entire left crus is exposed and all the attachments are released between the left crus and the esophagus. After complete mobilization, we divide and remove the umbilical tape, and this step is done in order to separate the anterior vagus from the esophagus. Normally the anterior vagus runs from left to right across the lower third of the esophagus. While doing this step, there are two advantages. It will not come in between while doing the myotomy, and at the same time the advantage of the esophagus is also lysed, so that what remains is only the muscular layer which needs to be divided during myotomy. Now you can appreciate the anterior vagus is completely mobilized. We have started esophageal myotomy. The myotomy has to be started first on the esophageal side, because it is relatively easy to enter a plane between the mucosa and the circular muscle on the esophageal side, and after completion of the esophageal side myotomy, then only we will come to gastric side myotomy. You can use different types of instruments, but normally what we use is a harmonic shear, and while using this harmonic shear, the active blade, the vibrating blade should be kept away from the mucosa so that will not perforate the mucosa. Even if there is any perforation to the mucosa of the esophagus, there is no need to be worried. Only thing you should do a fine suturing of the esophageal mucosa, and you can cover the esophageal suturing with anterior Dors gastric fundal wrap. That will actually help in preventing the leak post-operatively. Normally in esophagus which is not grossly dilated, once we take the harmonic shear, we will be able to complete the entire myotomy without changing this instrument. But here this is a very grossly dilated esophagus. You can appreciate the very thin mucosa. So in this case, we actually alternate between a curved dissector and the harmonic shears. The curved dissector is used to create a plane between the mucosa and the circular muscle fiber. While using this curved dissector, you should make sure that the tip of the dissector is facing the circular muscle fiber, and you have to slide it along the circular muscle fiber, not along the mucosa. And you can also appreciate the thickness of the muscle layer. You can see the circular fiber as well as the longitudinal fiber very nicely. This same myotomy can be done by using two curved dissectors on either side. You can tear the muscle fiber and you can go gradually cranially. The only disadvantage is it will cause lot of oozing, and once there is oozing or bleeding in this area, the entire anatomical plane will be obliterated and you will find some difficulty in identifying the proper planes. Here you can see it is absolutely bloodless, and with the magnification and the good light source, you can identify each and every fibers and you can divide it meticulously. This telescope is a 45-degree telescope which we use normally for fundoplication and hairless cardiomyotomy, which gives excellent view while doing a hiatal dissection. So this is the advantage of actually mobilizing the anterior vagus. Here you can see we are extending the myotomy cranially without the anterior vagus coming into your field. If you want to extend the myotomy some more cranially into the dilated esophagus, what you can do is you can use one instrument to the right cut end of the muscle fiber and the second instrument on the left cut end of the muscle fiber like this, and you can pull it downward so that you can get another 2-3 centimeters coming into the abdominal side, and you can extend the myotomy cranially. You can also appreciate the anterior vagus close to the tip of the harmonic shears. If you mobilize the esophagus nicely into the mediastinum, you can extend the myotomy further cranially. After completion of the esophageal myotomy, now we have come to the gastric side myotomy. We make a muscular incision about 2 to 2.5 centimeter below the esophagogastric junction, and gradually we deepen the division until we reach the submucosal plane. Here we will have one more layer, that is the oblique muscle fiber of the stomach, that needs to be divided. Once you reach the submucosal plane, you can appreciate the appearance of the submucosal vessels very nicely. You can appreciate here the submucosal blood vessels are coming into view. That means you have entered into the proper plane. So you can appreciate beautiful plane, that is the gastric submucosal plane. We have done myotomy of the muscle fiber, and we are in the proper submucosal plane. So you can appreciate the vessels which are coming into view. If you tear this vessel, there will be profuse bleeding. If there is any bleeding, you should not use energy source to control the bleeding. What you can use is, you can use a gauze piece, keep it over it and compress it. Most of the bleeding will settle down. And sometimes if you want, you can put a suture to control the bleeding. Because if you use a bipolar to control, there may be a chance of delayed leakage or delayed perforation. So that is close to the esophagogastric junction, and we have done a nice gastric side myotomy also. Can appreciate the completed myotomy. It has gone into the dilated segment, and also it has gone into the stomach for at least 2 centimeter. Once the myotomy is completed, we do an anti-reflux procedure, that is posterior 270-degree Toupet Fundoplication. We use non-absorbable suture. We take a bite between the right side cut end of the muscle fiber and the fundus of the stomach. The fundus of the stomach has come from the left side to the right side. Normally we take around 3 sutures on either side. You can appreciate while doing this Toupet fundoplication, the vagus is running anteriorly over the mucosa. We are gone to the left side. We are taking the fundus of the stomach to the left side cut end of the muscle fiber. Again we place around 3 or sometimes 4 sutures. Sometimes if you feel after completion of the posterior 270-degree fundoplication, sometimes if you feel that the hiatus is very wide, we can put 1 or 2 stitches to the crura, that is cruroplasty. That also can be done. In this case we actually used 1 stitch to reduce the size of the crural opening, so that the entire wrap will not migrate into the mediastinum. These patients should be put on nice antiemetic for few days, and if you are sure that there is no perforation, they can be started on liquid diets from first post-operative day. Normally this patient will stay for 24 to 48 hours. And another close-up view to check whether any residual fiber is there or not. With the close-up view, if you feel that there are few fibers running across the myotomy, you can use a Maryland dissector to identify and peel all the small fibers which is running across the myotomy site. So this is the completed laparoscopic LS cardiomyotomy with posterior 270-degree Toupet fundoplication. This is the advantage of laparoscopy, where we can add an anti-reflux procedure. Thank you very much.